We'll resume with another debate on adjuvant therapy. And this is actually a real whole debate, like 3 on the forum. So we're kind of upping it up here. So it's kind of like, I have to admit, really 3 giants in the field, kind of quite involved. Dr. Milind Javle from MD Anderson, quite well known for the work in the biliary cancer. And Dr. Jennifer Knox from Princess Margaret in Toronto. We actually, Jennifer and I work closely together. She's the vice chair for the Hepatic Biliary Task Force. And Dr. Ted Hong from the MGH, who is an expert in radiation therapy in the hepatic biliary field, and again, quite involved in the NRG, previously RTOG, as well as on the task force. So Milind is going to take the hardest task, or you know, they're all hard, I have to admit. But Milind is going to say there is no role for adjuvant therapy. Jennifer is going to say there is a role for adjuvant therapy. And that's going to say, wait, what about radiation therapy? So we're going to see that, and then we'll get the debate. So Milind, please.
Thank you, Ghassan, for that wonderful introduction. You know, before I start, I think this conference is really very close to my heart, not just because I get to meet the colleagues and friends we have developed in the cholangiocarcinoma community, but I can get to talk to patients, families of patients who have passed away, and they're still here to support our cause. And I just met a young man today who I know rather well, actually. Didn't meet him for the first time, but the patient, I took care of his wife, very young child, and it was very hard to lose her. But I think it's very satisfying that we continue to be a part of each other's life. So thank you for being here. And I'm going to talk a little bit about adjuvant therapy for cholangiocarcinoma. And it's a bit challenging because I think both Jennifer and Ted are people whose work I greatly respect. And we all sort of agree, and yet in this debate, we have to take counter positions against each other. So my role is no role. My topic is no role for routine use of adjuvant therapy for cholangiocarcinoma. And I thought of dividing it into these following categories. First is, if we give adjuvant therapy, or that is additional therapy after surgery, who are the patients that we would choose? You know, these are patients who have some high-risk features. How well do we conduct surgery? So this is a non-surgeon discussing surgical trends in the US, and they don't really apply here very much because we have really top quality surgeons here, but what do we have out there in the community? What is the level of evidence? So Jennifer has some nice studies, so has Ted and several others in the room, but does it meet the bar of actually changing practice? And then finally, a theme of this conference is molecular profiling. What can we learn from molecular profiling and apply it to our patients who undergo surgery and post-operative therapy? So there's a patient from my practice. She is in her 50s, really healthy lady who presented slight elevation of liver function tests, went to a doctor, and surprisingly, they found this tumor in the liver. As you see, this is a relatively small tumor. She met her surgeons, and he said, look, we're going to get this out, and most likely you're going to be cured forever. She got no adjuvant therapy. And then by the time I saw her, which was like a year and a half later, she had disease recurrence in the liver, in lymph nodes, in the peritoneum. So clearly we don't have all the answers, and on reflection, could we have done anything better to improve her outcome? So I think some of this guidance as far as which patients have high-risk features have come through large patient series, such as this one. This was an international multi-institutional collaboration, Tim Pollock's group in Johns Hopkins. They looked at 450 patients throughout the world treated at tertiary centers. Now, most of them had solitary tumor, just like the woman whose scan I described, 73%. Median tumor size was 6.5 months. Unfortunately, the median survival was, in this entire series in tertiary cancer centers, was a little over 2 years, and 5-year overall survival was 31%. So I also treat pancreas cancer, and I'd say this is just a little better than that, but just a little. So clearly we have to do more. What they said was tumor size is not prognostic, irrespective of the size. Prognosis was variable. The adverse factors were positive margins, multiple lesions, and vascular invasion. These predicted recurrence. The other very strong factor was lymph node involvement, and in the next few slides, I would describe the role of lymph node dissection, how well we do it, and what implication that will have on the clinical care of our patients. So in this large series of 400-odd patients, they removed lymph nodes, lymphadenectomy, in 55%, and they found 30% had lymph node disease. They said lymph node disease had poor outcome, which we know that from several other cancer types. So their conclusion was that we should routinely perform lymph node dissection. And we know from treating other diseases, gastric cancer, colon cancer, pancreas cancer, that removing lymph nodes matters, and you can improve their outcome just from the lymph node dissection, not necessarily from the chemotherapy or radiation that would follow. So how well do we do it in practice? So this is the SEER registry. Now the SEER registry, as you know, is a registry of patients who get treated in community, who get treated in cancer centers, but it's a real life look at what happens. This is a registry of 5,000 patients treated from over about 10 years. Unfortunately, lymph nodes were evaluated only in 13% of patients. That's 600 patients out of 5,000. And a median number of lymph nodes removed were 2. The 5-year survival in this group is rather poor across the community. I'm not sure how I could use a pointer, but if you see that figure on the dark blue line over there, this is patients who never had any lymph node sample or unknown nodal status. Patients who had positive nodes, the line in the green, of course, did worse than patients who had negative nodes. But the folks who did the worst was those who had no lymph node sampling at all. Now let's look at another slightly different type of cholangiocarcinoma. This was intrahepatic cholangiocarcinoma. Let's look at the trend in perihilar carcinoma. This is over 1,000. This is again the SEER registry. Over 1,000 patients with perihilar carcinoma resected over 10 years. They found that, so it's my understanding from the surgeon is that it's easier to remove lymph nodes in perihilar carcinomas, unlike intrahepatic. So they removed on an average of 6 nodes in this series. But when they looked retrospectively at what was the ideal lymph node count that would impact on survival, they said that more than 13 lymph nodes was associated with a survival benefit. So clearly it seems like when we remove lymph nodes, we are not doing a very good job, either in the intrahepatic or in the perihilar setting. We're just not removing enough lymph nodes to impact the clinical care of our patients in a significant way. Now, because a lot of the series that we are going to discuss today, and Jennifer's article and others, included both intrahepatic cholangiocarcinoma, extrahepatic cholangiocarcinoma, and gallbladder cancer, which we all in this room recognize are different diseases. I'm going to touch briefly on gallbladder cancer because this is going to be referred to in the subsequent part of our debate. We know that radical resection, removal of the gallbladder, removal of lymph nodes, removal of the hepatic bed is associated with improved survival. The dashed line shows an improved survival over those who receive standard cholecystectomy. Unfortunately, the current surgical management is suboptimal. The proportion of patients who have radical surgery is very poor in the community. It's less than 20%, as a matter of fact. And this trend has not, unfortunately, improved over time. So we don't perform radical resections either in cholangiocarcinoma or in gallbladder cancer on a routine basis. Part of this reason is perhaps these are patients who are treated in community, these are infrequent cancers. It's not a situation of colon cancer and breast cancer. So standards are not that well established. That leads to inadequate lymph node assessment, and I think it certainly contributes to a poor survival. So survival, despite surgical resection, is poor, in my view, partly because patients don't get adequate or appropriate surgeries. So what should then be our strategy to improve outcomes? Should we continue to perform suboptimal surgeries and then give a lot of chemo afterwards and radiation afterwards? Or should there be a role for better surgical technique or better surgical outcome? This is a question I think our debate is addressing today. So what about post-operative adjuvant therapy? There's adjuvant or post-operative therapy is very well established in colon cancer and breast cancer, but really in few diseases is the level of evidence very strong, and it's certainly not very strong in my view in cholangiocarcinoma. There is no level 1 evidence, that is a randomized phase 3 study, which will, for instance, YA performed a phase 3 study comparing gemcitabine, cisplatin, level 1 evidence that showed 2 drugs better than 1. There is no such evidence in terms of adjuvant therapy. They are primarily retrospective, single institution or population-based registries, and a lot of biases come into play when you look at that sort of data. See, the NCCN recommends that adjuvant therapy should be considered after surgical resection for high-risk disease. And there are several ongoing trials that we are all a part of, but these trials have been going on for close to 10 years, some of them. So I don't think we're going to find the answer very soon about whether post-operative adjuvant therapy helps. Let me give you an example of one so-called positive trial from Japan, where patients after surgical resection received chemotherapy. It was a phase 3 trial. They received mitomycin, 5-FU, drugs, a combination that we would rarely use in practice. They included pancreas cancer, intrahepatic cholangiocarcinoma, extrahepatic cholangiocarcinoma. They showed some survival improvement. However, you really are using a regimen that's very toxic for a disease that is extremely heterogeneous, so you really can't make much out of it. So when you pool a lot of these smaller studies and registry-based analyses, you can create a meta-analysis, such as Jennifer and her group did from University of Toronto. And I think this was a very important piece of work, which looked at over 6,000 patients from across various clinical trials and registries. The major contributor to that study, the meta-analysis, were the SEER registries, although there were some trials included. The maximum number of patients came from there. So they showed that there was basically a non-significant improvement with additional therapy, adjuvant therapy after surgery. The P was 0.06. And this study included gallbladder cancer, intrahepatic cholangiocarcinoma, extrahepatic cholangiocarcinoma. And to the sophisticated audience that we have here, we know these are different diseases. So when you look at bile duct cancer independently, it was even less significant. P-value was 0.10. Can we say much about intrahepatic cholangiocarcinoma? Not really. The patient numbers were extremely small. That is 11 patients. They noted that radiation alone did not work, but chemotherapy or chemoradiation had a statistically greater benefit, and that is an important observation. But beyond that, to my mind, based on this, to make an adjuvant therapy recommendation, for instance, after resection of intrahepatic cholangiocarcinoma, is somewhat challenging. Now let's look at perihilar carcinoma. So if you look at the SEER registry, this was an article published actually earlier this month. They looked at the SEER registry for patients with perihilar carcinoma who had surgical resection. And when you looked at node-positive patients, there's 200 patients in each group, people who got post-operative radiation therapy and versus patients who didn't get post-operative radiation therapy, there was no significant difference. So we recognize that adjuvant therapy is sometimes worth considering, but in my view, the data are rather weak. In terms of a study like this from the SEER registry, there's a lot of inherent bias when you offer someone radiation. These are people who have already recovered. These are people who have relatively good performance status. In other words, people who you think can handle chemoradiation. And even in that population, in a retrospective analysis, if you don't show a survival benefit, I think to offer it prospectively without a trial is somewhat challenging. There are ongoing trials which will give us guidance. These are trials, 3 of them are mentioned here, which are ongoing. They've been ongoing, shall I say, for a very long time, 2006, 2009, 2008. The only trial that is completed is the last one that was led by Anthony here. This is a single-arm prospective trial of extrahepatic cholangiocarcinoma. Very impressive trial where people got Gemzar, Zelora, followed by chemoradiation. However, there was no control arm. So we don't know really based on that arm. And I know that trials are being planned to follow up and to find the good comparator. But I think in an effort to help our patients, I do appreciate some of the work done by our European colleagues that while the standards are not established and the data are weak, probably we just need to put these patients on trials and not offer them therapy based on our best clinical judgment. Now, going further, can we improve our patient selection? Can molecular profiling play a role? We had several elegant talks this morning on genetics and the role they play in this cancer. So our registry is now updated. We have, this is a larger series of 400 patients with intrahepatic, 57 with extrahepatic, and 85 with gallbladder cancer. And these are the demographics. The point to note is these people are quite young, in their 50s, who are getting these cancers. And we see this sort of genomic distribution, and I show this tail to indicate that the taller bars here are mutations we cannot target. The taller bars are KRAS, P53, those are genes that, or CDK2A, P16. These are genes for which we do not have good treatments. But there's a long tail, and on that long tail, you find FGFR, you have IDH, ROS1, and other mutations for which we have trials. And these may not mean much for the whole population, but they mean a lot for that individual patient. So I think it is important that we look for that, that molecular profiling plays an important role. We saw a similar curve in extrahepatic and in gallbladder cancer. And this is just the distribution of these cases to show that these tumors are intrinsically different. Now, I find it most impressive that in intrahepatic cholangiocarcinoma, which is the first column here, you have BRAF in 5%, you have FGFR in 11%, 20% have IDH, and these are good numbers. There are 400 patients. So over 35% of patients have mutations that we can target. And I think in no other GI cancer does this exist, certainly not in colon, certainly not in gastric. So I really think we are at a threshold of making some major changes in this disease, which we will see improved outcomes, I think, in our lifetime. Extrahepatic cholangiocarcinoma looks a little bit like pancreas, or like the one Supong just described from Thailand, KRAS, P53, and gallbladder cancer, the low-hanging fruit is ERB2 amplification, as Maeve showed. We need a study. There's no advocacy in that disease. This drug should be approved, Herceptin and those sort of therapies. And lastly, how can we use this molecular profiling for prognostic stratification to choose patients for adjuvant therapy? So there have been several adjuvant therapy trials. There have been several retrospective analyses. I like to think this is probably as large as one could possibly get, because totally this is about 600 patients. So if you look at P53 or KRAS, these are mutations which have prognostic implication. Especially KRAS has, you see the red line, it has, there is an important difference here. What also stands out is that FGFR mutation or FGFR fusion have an intrinsically superior, have an improved prognosis. So I have a patient right here in the audience who has cholangiocarcinoma for 6 years, and although she loves me, the reality is her tumor is quite indolent. So her FGFR is a slow-growing tumor. So I think how can we use these stratifications in a rational way for adjuvant therapy? Perhaps patients who have surgically resectable cholangiocarcinoma and FGFR fusion, certainly they don't need any adjuvant therapy. They probably have a good prognosis. Patients who have an earlier stage disease, even margin negative tumor, and have KRAS, these may be patients who actually benefit from an aggressive adjuvant therapy. So I think in trials that are going forward, we have to look beyond techniques that we have used really for 100 years, lymph nodes and margin, and go positive, more towards molecular classification and stratification. So these are the last few feel-good slides, which all of us love. This is the FGFR trial that Anthony has already described. Currently, we think the median survival is not reached, but it seems to be at least over 6 months. And these are patients who respond to FGFR-targeted therapy after having 2 and 3 prior treatments. It's very difficult to present slides when you have a family member right in the audience. But this is a young lady who had a BRAF mutation, who really kind of came with close to hepatic encephalopathy. It was just slid into the trial, and within a week started feeling better. Unfortunately, the response was not very long, but BRAF is not common, but BRAF mutation in cholangiocarcinoma responds very well to BRAF inhibition with dabrafenib and trametinib. It's just finding the mutation result in time is a challenge, because the sequencing often takes 6 weeks, 2 months. EGFR amplification in gallbladder cancer, this is the role of erlotinib. So, Juan, I was asked to remind you that erlotinib works. And BAP1 mutation, Maeve described this earlier. This is a patient, this mutation can have an adverse prognosis. This is a patient who had surgical resection. It was a very challenging surgical resection, but it was successfully performed. And really within 2 months of surgical resection had multiple mets. So is this a situation that we really need surgery at all? Is this a situation we need aggressive adjuvant therapy? I think these are the questions we will be asking down the road. So this is my final slide. In my view, routine use of adjuvant therapy is not indicated. I think we all would agree that we can't prescribe it for everybody. But even in the so-called high-risk categories, there is a lot of room for improvement in order to understand them better. So high-risk groups can be offered clinical trials of chemo and radiotherapy. And I think molecular prognostic subgroups will have a significant impact on decision-making. Ideally, all the resected patients should be enrolled on a prospective profiling registry. So I thank you very much, Ghassan, for your kind invitation.
Shoes. Okay. All right. So good morning, and thank you very much to the cholangiocarcinoma group for inviting me. I'm delighted to be here in Salt Lake City, and I must say I'm incredibly impressed with the program and the audience and the amount of work that's gone into this, and I'm feeling very optimistic about the future in this area for advancement. I've been given I suppose it might be a somewhat easier topic than the NA side of things, because everybody likes to treat patients. And it's not perhaps the most progressive molecular topic to discuss. But I think it's important for us as clinicians to be able to have opinions, policies, and advise our patients to the best of our ability, even though the data is lacking. So I'm taking the side that in adjuvant approach to biliary tract cancers, there is a role for chemotherapy. So to get you thinking, let's start with a case. This is a very typical case. This is a 67-year-old man who has now had a very modern, state-of-the-art resection of an extrahepatic cholangiocarcinoma, and he's sent to you as a medical oncologist for a discussion of adjuvant therapy. He has no significant comorbidity, so odds are he will die of cholangio more so than other diseases. He's 6 weeks post his surgery. He has a great performance status. He's been staged, and there's no early recurrence or anything missed. And his pathology reports a moderately differentiated T3 node positive clear margin tumor. So your best recommendation is, and we've all heard there's data lacking, so you have to be rational and reasonable and safe in this setting. So I've put down a number of options. You don't have to vote or anything, but think about them a bit. So should we use FOLFIRINOX? Because good heavens, if it can work in pancreas advanced disease, it should be able to do anything. Should we look at some 5-FU in combination with radiotherapy? That's certainly a long-standing approach that many centers have taken. Should we look at a single agent drug with some history like 5-FU or gemcitabine? Should we do both, some chemoradiation and some systemic therapy? Should we advance the hypothesis that the cisgem couplet is more effective than a single agent in the metastatic setting, so therefore it should work in the adjuvant setting? Or should we observe them given the lack of data? So some things to think about, and I know when I've polled audiences at other presentations, it's been surprising the spread of answers, including FOLFIRINOX. So I put up Charlie Brown. He says, sometimes I lie awake at night and I ask, where have I gone wrong? Then a voice says to me, this is going to take more than one night. So I thought of this because I kind of echo some of the comments earlier. It's a rare disease, it's a challenging disease, and we haven't collaborated enough in the last 30 years to try to take straightforward questions like adjuvant approach to resection forward, and then you start to think that this disease lags behind what is sort of taken for granted in more common cancers. So if there's a take-home message, I really want us to collaborate and do these studies and buy into these studies and advance the field. So just to back up a little bit, this is, I think, Webster's dictionary definition of adjuvant therapy. It is additional cancer treatment given after the primary treatment with the intent to lower the risk that the cancer will come back. So just for the purposes of this conversation, we're not talking about downstaging to surgery. We're not talking about pseudoadjuvant. We're not talking about anecdotal experience with targeted agents, and we're not talking about neoadjuvant therapy. We're talking about curative intent surgery followed by a therapy. So as we all know, biliary tract cancers is a spectrum of disease, and with the molecular profiling, we're starting to have a better understanding of that, and I'm so glad that is happening. We've been sloppy in our nomenclature for so many years. In fact, when we went back and we did the meta-analysis, it was very difficult to find out for the longest time. You know, in some studies we couldn't use them because they didn't define what kind of cholangiocarcinoma it was. And even clinicians today are sloppy, and they say bile duct or cholangio, and there's no definition of intrahepatic, extrahepatic, hilar, gallbladder. And you know, their outcomes can be different. So as we know, it's uncommon. It has a poor prognosis, and depending on what series you look at and what kinds of patients were included, you get slightly different numbers. Certainly surgery is the mainstay of therapy and offers a cure, but again, that's only in the 30-40% range, and then so many patients already present with advanced disease, and surgery isn't an option. And it's been well recognized for a long time now that relapses occur both in the local area, local, regional, and systemic. And there's a little bit of debate as to how that breaks down. The sort of classic paper by Dr. Jarnigan was that cholangios recur locally more and less systemically, and gallbladder recurs more systemically. But even more modern series might suggest, including the SWOG study, that adjuvant study, that these are more similar in the recurrence patterns than we might have thought as well. Now, this is just showing our Princess Margaret data, and it's no better than other excellent institutions, but I show this because the comment was made of good surgery. So this is surgery in a center of excellence in a modern era where gallbladder resections and node resections and everything happened. And the point of this is it doesn't really quite matter here what type of biliary cancer you have. You know, the recurrence rate is very high. Time to recurrence 14 months, and the overall survival isn't great. This is quite a high node positive population, 22 months. And of course, like so many other institutions, when we looked back and we did multivariate analysis on who got chemo and who didn't, there certainly is a message that chemotherapy seemed to give patients an advantage. But these types of studies are incredibly biased and difficult to interpret. But to be fair, a fairly consistent message has been seen across all these different institutional studies. So when you think about what resources do we have to turn to answer this adjuvant question, we've got the, what has already been pointed out is that we really don't have a lot of randomized data and good level 1 data, and so we have a lot of these non-randomized trials. We do have the meta-analysis that we did, and I, with all its caveats that it was much older data, and we had to rely very much on what investigators had reported in their papers, and we couldn't get individual data on many patients. And thankfully, we do have the ongoing randomized trials that we'll read out soon, I hope. So just briefly about that meta-analysis. So when we set out to do this, we were a bit surprised by how many studies there actually were. So whenever you have an area where you don't have a good answer, there's a lot of people trying to add to it. But basically, we accepted studies in which patients had gallbladder, intrahepatic, perihilar, or distal bile duct cancers. We excluded all the ampullary ones, and there were a lot of those. And then they had to have some type of adjuvant therapy, whether it was chemo, chemorads, or both, or radiation alone. And there had to be a curative intent surgery, so that right away, many studies where there were R2 or debulking palliative surgeries were thrown out. We had to include patients that had a curative intent alone as a comparative arm, even though in some cases it wasn't randomized data. And it had to be an R0 or an R1 resection. Many papers wouldn't even mention the margins, so we threw those out. And so here's the overall meta-analysis. So you can see by the forest plot that all the gallbladder studies here, all the cholangio studies here, and an overall trend towards benefit by any adjuvant therapy, but not quite making statistical significance, p.06. Now, and again, I think it's very fair to point out that a lot of this data is older. Most of these patients were treated with 5-FU. There's some gemcitabine coming forward in later studies, but all of this is 5-FU or 5-FU based regimens. And it's absolutely correct. Nobody was putting any intrahepatics on any of these publications. In fact, I remember when I was new in GI oncology, and I used to get sent these intrahepatic cholangios, and they were called unknown primaries, right? And so I think our understanding of what these are has really evolved really very recently. And so some of these early studies wouldn't even have considered an intrahepatic cholangio. And we did plan from the beginning to look at the two subsets of high risk. We couldn't tease out all the high risk features, but we did plan to look at the node positives and the R1 resections. And so this is where the data gets a little more convincing. So both for the node positives and for the R1 resections, there is statistically improved for adjuvant therapy. And as was mentioned, 3/4 of these were chemotherapy-based regimens, 23% were chemoradiation, and some were both. So when we set out to do this, by no means did we think there was going to be the quality of data was going to settle this question. What we really wanted to do was try to engage and get agreement and collaboration around the world, and certainly around North America for sure, to try to agree on our policies and to move forward for clinical trials. And so some of our conclusions were, as listed on here, given that overall there wasn't a statistical improvement in relatively low-risk patients, no molecular profiling, of course, it would be certainly reasonable that a trial of low-risk patients could include a no treatment arm, which is happening in the European studies. But in the higher risk patients, simply node positive or R1 resections, there seemed to be a benefit. And there it makes sense to perhaps try to then fine-tune what is the best adjuvant, safest, most beneficial in that population. So that's the one in which different types of treatment arms could be compared. And perhaps the mainstay of my talk here is, until we have that better data, your treatment policies can be guided by these findings until you have better data. And then, of course, while this was going on, the UK group published this important trial that showed that a doublet chemotherapy was better than gemcitabine in advanced disease. So the paradigm in oncology is always, if it works in the advanced, it may be effective in the adjuvant so this has implications. So now we might have more consensus on what regimens to study, and also some momentum that you can actually do randomized trials in biliary cancer, and they're important. So as mentioned, there are some ongoing studies. So the one that got started first was the UK BILCAP one, very pragmatic, pretty much all comers, capecitabine or observation. So this study has completed accrual for some time and is maturing. So we look forward, I think ARMS might be doing a little better than expected. So we look forward to seeing that readout, I'm guessing next year. This year, Juan, great. See, good. And then the French also did this study where they looked at pretty much all comers resected GEMOX versus observation. And we are kind of expecting that this year. They've been very quiet, so we haven't heard, but hopefully we'll have that data. So there's some pure chemotherapy questions, although it doesn't help you with the doublet. Well, we'll see what the data shows. It might help with the doublet versus single. And then the Germans, in collaboration with the Brits, have started this GEM-CIS versus observation a couple years ago. And I believe the Japanese have a S1 versus observation. So I don't think we have to wait too long until we'll get some really level 1 data. As was mentioned, the SWOG study that looked at a combination of GEM-CAP and capecitabine during radiation has been has been helpful, even though it's not a randomized trial. It basically has shown some feasibility of accruing to these kinds of trials in North America, and accrued nicely. One of the strengths, I think, of this trial is the central review that took place for the pathology, for the operating records, and for the radiation plans. And so when you do a study like this, it lifts the bar of quality. And I understand quite a large number of patients who were referred for adjuvant had not had curative surgery, and that's part of the message about trying to improve the standards of care in community centers as well. Anyway, this was designed to look at the R1 versus the R0 strata with different outcomes expected, but both arms did very well, which hints at the idea that perhaps these are effective adjuvants. But in the lack of a control arm, we can't say too much more than that. It does demonstrate some safety and feasibility of delivering a doublet and radiation in this population, which also reassures the clinician if you're going to treat somebody outside of level 1 evidence or office study. Now, the NCC guidelines, I'm not going to go through all this in detail, but essentially, they're really sitting on the fence. So, you know, if you have a low risk cholangiocarcinoma, you could observe, you could give 5-FU radiation, you could give 5-FU, you could give GEM, or you could go on a trial. So they're really narrowing it down for you. And, you know, I won't go through them all, but basically expert opinion in a difficult situation. So I bring this up. So the cartoon is making fun of decision making. So unfortunately, when you have a patient in front of you, you have to make a decision and try to recommend what is best for them. So adjuvant therapy for biliary tract, I think there is a role. In the absence of ideal data, we have to be rational, reasonable, and safe, okay? So we have lots of examples from other areas of oncology, including GI, where a little bit of mild chemo like 5-FU can impact on outcome. So if it works in colon and gastric and pancreas, it's reasonable hypothesis that it'll have some impact in biliary cancers. There is a long history of using 5-FU or capecitabine and gemcitabine as safe adjuvants, so there isn't a body of evidence of danger with these drugs given over 6 months. And so I don't feel nervous about making a patient worse by giving them these drugs. And we know that these patients are at high risk of recurrence, and I think patients can understand the gray zone with a little explanation. And usually I talk to them and discuss it, and most patients will advocate for having chemotherapy, even though it's not ideal data. So if we go back to my case, again, of an extrahepatic, I've left the intrahepatic out because, again, I'll be the first to say the data is close to non-existent in that group, and the discussion is even harder. And I tell patients that. But in this extrahepatic, who would probably tolerate chemo very well, you have to make a recommendation. So here are my biases. I think that a single agent chemotherapy for 6 months is a very reasonable thing to do. I think based on the SWOG data, I think chemoradiation plus a single agent is also very reasonable to do. I put a question mark next to the GemCis, and I know people disagree with this, but again, I think it's an additional leap of faith to assume that the doublet will be better than the single agent. And then when you add platinum to chemotherapy, you do add quite a bit more toxicity, thrombosis, renal toxicities. And the therapeutic index here in these cancers is probably very small, so it needs to be tweaked. And we learned from colon that the lion's share of an adjuvant benefit comes with 5-FU. Irinotecan didn't add anything to that, despite being a more active drug. And FOLFOX, while better, is still not the home run we thought it would be. So that's why I think that should be held for clinical trials. So very briefly, benefit is still unclear. Optimal approach is unclear. The meta-analysis allows you to have a little bit of comfort to guide decisions now. We're going to get readout in clinical trials fairly soon, which I hope will be very informative. And as much as I'm a fan of all this discussion of the molecular biology handled brilliantly this morning, it just isn't ready for adjuvant. And again, we need to be able to really know what patients to treat in the advanced setting before this can move into the adjuvant setting. So there is hopefully a North American trial coming soon, and maybe we can bring in some international collaborators that's going to look at chemotherapy and chemoradiation. So I put up the American and the Canadian flag here because it's dear to my heart. So that is my argument, and keep calm and chemo on. Thank you.
Well, thank you very much, and thanks to the conference organizers for inviting me. I love how all three of us thought that we had the hardest task in this debate, but I am convinced that I have the hardest task because I have to follow those two great talks. But the other point I just want to make is your agenda says I have 5 minutes, but I've been reassured that I have more than 5 minutes, so lunch is going to have to wait a little bit. But I'll try not to take too long. These are some disclosures that I have. Okay, so radiation is very controversial in cholangiocarcinoma, and I would argue for a very good reason. Back in 2005, when I started my clinical practice after finishing residency, this was a year after the SPAC trial had been published in the New England Journal of Medicine, which really kind of either shed doubt if you ask a radiation oncologist or put the coffin in if you ask a non-radiation oncologist in the role of post-operative radiation therapy in pancreatic cancer. And this is due to what became an avalanche of negative trials, including the EORTC trial, an SPAC trial in the adjuvant setting, and the FFCD and the LAPO-7 trial in the locally advanced setting. When one looks at the patterns of failures in these trials, the local control benefit is actually highly questionable. And even if there was a local control benefit, the high metastatic rate in pancreatic cancer would obscure any overall survival signal. Currently, RTOG 0848 is accruing, but certainly when you're talking about the same surgery, namely a Whipple for extrahepatic disease, or perhaps a more extended hepatic resection for a Perihilar cholangiocarcinoma, what was going on in pancreatic cancer certainly wasn't helping make the case for radiation therapy in resected cholangiocarcinoma. As talked about by both Milind and Jennifer, the data is very poor quality, and I would argue that for radiation, the data is even a step lower in quality than the adjuvant data in chemotherapy. We're largely limited to single institution retrospective reviews, and large databases that are prone to all the biases that Milind mentioned, and with limited single patient data regarding radiation technique, make the majority of these patients included in these SEER databases. And additionally, as has been discussed by every speaker this morning, we're really talking about a whole bunch of different diseases. And the radiation series all include a mix of patients with hilar, distal, or gallbladder cancers, rendering it very difficult to draw any conclusions. I'll also echo what Jennifer mentioned, which is there are not actually any series that have looked at radiation for intrahepatic cholangiocarcinoma, so I can't even begin to discuss if we should be doing radiation for intrahepatic cholangiocarcinoma after resection. So this is an example of the kind of data that we have. This was a large series from Korea that looked at radiation, and they did a nice job summarizing what some of the other adjuvant studies evaluating radiation looked at. And rather than looking at these numbers and outcomes, what I'd like to draw your attention to is these numbers. These are very small studies. Clearly, people who can get chemoradiation may have been more likely to get chemoradiation. And if you just were not a chemoradiation candidate, you were in this group, making any of these numbers very difficult to assess. The other thing that I would point out is that when you're doing radiation therapy, you're trying to impact local regional control, and look at all of this great data that tells us if radiation is helping local regional control. So this is a real issue in terms of how do we know that radiation should be offered for a resected cholangiocarcinoma. This is a SEER series. It's a different SEER series because it was published in a radiation journal, as you can see here. Let's see if I can go back here. Okay, so clearly if you have a study published in a radiation journal, this one is going to show that there is a benefit to radiation. But again, the issue is same database, different selection criteria. And again, what I would echo what Milind said, which is, geez, if you're healthy enough to actually get radiation after surgery, maybe you were just a healthier patient in the first place, because if you weren't healthy enough to get surgery or radiation, then you weren't going to do as well. So I think that the amount of bias in all of these studies is really substantial and not trivial. The last thing that I would mention is that chemoradiation is really hard after five and a half weeks after you undergo a major upper abdominal operation. These are not easy operations to recover from in the first place, and under the best case scenario, chemoradiation to the upper abdomen is not terribly easy. And when you add the two together, I think we really have to be careful about what we're recommending to our patients if we're going to be making this recommendation after such big surgery. The transplant issue, I think, is going to be discussed this afternoon, so I'm going to skip that. So I don't disagree with any of these arguments, and I don't think radiation in cholangiocarcinoma is a given, and I think that this debate is very healthy. But what I would like to do is look at some of the issues about what our underlying assumptions are regarding extrahepatic cholangiocarcinoma and try to see if we can understand better why there may or may not be a rationale to think about radiation therapy. So first of all, cholangiocarcinoma isn't pancreatic cancer, at least from a radiation perspective. Again, understanding that the presentation for some patients may be similar with the presentation of jaundice, and the surgery may be same for distal common bile duct tumors, being a Whipple, the outcomes are different. Now, you can very much tell that Dr. Javle and I may have had a little bit of a difference in terms of glass half full, glass half empty, but I would argue that the outcomes for pancreatic cancer are actually substantially worse than the outcomes for extrahepatic bile duct cancers. You know, I think we can look at, is there a 10 to 20% difference, or are you twice as likely to be cured with surgery? I take care of a lot of pancreatic cancer, and I think that this difference is actually real and clinically meaningful. But there's another issue, and this is a study that Jennifer mentioned as well. This is a study from Memorial Sloan Kettering, published by Dr. Jarnigan, where he looked specifically at the patterns of failure from extrahepatic cholangiocarcinoma, and he was really looking more specifically at hilar cholangiocarcinoma, as opposed to gallbladder cancer. And what I found very interesting is the number of patients with local regional recurrence alone, 38% in the extrahepatic group as opposed to 9% in the gallbladder group. But in terms of number of patients with distant recurrence, there was a higher rate of recurrence in the gallbladder group and only a 26% rate of recurrence in the extrahepatic cholangiocarcinoma groups. Other series have modified numbers around this theme, but ultimately, extrahepatic cholangiocarcinoma actually seems to have a real local regional control problem that may not be outstripped by the distant metastatic risk. Therefore, the patterns of failure are different from pancreatic cancer and gallbladder cancer, demonstrating this dominant local regional pattern of failure. And I would argue that even without survival data or benefit of survival, the issue that arises from local regional recurrence in extrahepatic cholangiocarcinoma that could lead to jaundice again, but then no opportunity for internal stenting, therefore percutaneous stenting, is a real quality of life issue. Many of us in this room have taken care of patients with percutaneous stents, and we recognize that our patients can often undergo a lot of pain. It's a big infection risk. It could be a very challenging journey for the patient, and for caregivers, a medically very complicated situation. So the question then is, if we really believe that there is a local regional issue with radiation therapy, will radiation work? And it's highly questionable, given that, again, I said in pancreatic cancer, I don't think the data is very clear if adjuvant radiation actually impacts local regional failure after a Whipple. And the question then is, should we expect anything different from cholangiocarcinoma? This is a data set from Mass General. It's a much smaller data set than what Milind just showed, but it's one that got us thinking about, are biliary cancers different than pancreatic cancer? And what you can see here is this is divided up by cholangiocarcinoma and gallbladder cancer. And what I want you to focus on is this KRAS mutation rate, demonstrating in cholangiocarcinoma a KRAS mutation rate of under 15% and even lower for gallbladder cancer. And when you split it out by intrahepatic versus extrahepatic, you can see a much higher rate of KRAS mutation for extrahepatic cholangiocarcinoma. And even if, as Dr. Javle's slide showed, even if this is up to 40% in extrahepatic cholangiocarcinoma, we're still not talking about 90% as in pancreatic cancer. But I'm a radiation oncologist, and I'm not talking about inhibition of the MAP kinase pathway or the PI3 kinase pathway or any other KRAS-directed therapy. Why am I talking about KRAS mutations? It's because KRAS mutations actually matter greatly in radiation therapy. KRAS mutations have predicted for radiation resistance in multiple preclinical models, and clinical data supports poor radiation responses in KRAS mutant tumors. This is some seminal work that was done by Gillies McKenna back when he was at UPenn before he went to the Gray Lab in England, demonstrating in a colon cancer model that if one had a mutant KRAS allele, it was somewhat radiation resistant, and then if you could knock out this KRAS mutant allele, it restored radiation sensitivity. And this experiment has been repeated ad infinitum at multiple radiobiology labs now, and this is a generally accepted marker for radiation resistance. There is also some clinical evidence in some other disease sites suggesting that KRAS matters for radiation. This is one such data set from Memorial Sloan Kettering where 132 patients with stage 2 or 3 rectal cancer were treated with standard chemoradiation, and multiple genes were evaluated to demonstrate who would be more likely to have a pathologic complete response. And what one can see here is if you look at the top line for KRAS mutant tumors, the group that had no pathologic complete response was enriched with KRAS mutant tumors, in contrast to the group of patients who had a pathologic complete response that had a lower likelihood of having KRAS mutant tumors. We ran a similar experiment at Mass General where we looked at 47 patients that we treated and then did a similar mutational analysis. And what we found is that in these 47 patients, we had about a path-CR rate of about 24% in the KRAS wild-type patients, and only one of the RAS mutant patients that we treated had a pathologic complete response. This has also been shown in other disease situations or other radiation modalities. This is KRAS mutation as a predictor for local recurrence after lung SBRT. So now we're talking about very high doses on the order of 12 gray times 4 for relatively small tumors. And what you can see here is if you have a KRAS mutant lung cancer, you are statistically more likely to have experience local failure than if you have a KRAS wild-type tumor. And this is some data from a proton study that we did at MGH where we treated patients to 50 gray with liver metastases from a variety of other solid tumors. And we were very interested in what was going to predict for local control after liver SBRT. So again, 50 gray delivered in 5 fractions, very high dose radiation. And it turned out it didn't really matter if it was colorectal metastases or others, if it was adenocarcinoma or something else. If you had progressive disease at the time of our treatment versus stable responding metastatic disease, it didn't matter if you had single or multiple tumors, it didn't matter if you had big or small tumors, and it didn't matter if we got to 50 gray or if we couldn't get to 50 gray. It turned out what mattered was whether or not the patient had a KRAS mutation in their tumor, and you can see here that the 1-year local control was 77% in the KRAS wild-type tumors, but less than 50% in the KRAS mutant tumors, in spite of the fact that we were giving very high doses of radiation, and this is graphically represented here. So How does radiation work then in intrahepatic cholangiocarcinoma, which I think most of us would agree seems to have a markedly lower mutant KRAS rate? Well, this is another study that we did together with Milind's group at MD Anderson, where patients with hepatocellular carcinoma or intrahepatic cholangiocarcinoma with unresectable tumors received 67.5 gray in 15 fractions. And what you can see here is in the 40-plus patients who had intrahepatic cholangiocarcinoma, the 2-year local control was about 90%, graphically represented here, though admittedly there were some late recurrences. Suggesting, though, however, that with radiation alone, these large tumors, again, the median tumor size was 6 centimeters, it was possible to achieve long-term local control for an unresectable intrahepatic cholangiocarcinoma. The group at MD Anderson also had another paper that was recently published in JCO demonstrating that, in fact, if you could get to a high enough dose of radiation, then one can expect really excellent local control with further evidence of long-term survival. Again, encouraging data for this hard-to-treat, high-risk group, but again, a suggestion that radiation can be a very effective modality in a group of patients enriched for KRAS wild-type tumors. Now, again, given that there's limited data, I think all three of us now have shown this study because it's the only prospective US-based or North American-based adjuvant data. This is a SWOG study, a single-arm phase 2 study, as discussed by Jennifer, extrahepatic cholangiocarcinoma or gallbladder cancer. Somewhat higher risk in that the tumors had to be, could not be T1 tumors, or they had to be node positive, or have a positive margin at the time of resection, and they received gemcitabine and capecitabine for 4 cycles, followed by chemoradiation to 54 gray. And this is, in fact, the exact same survival curves that Jennifer showed, but the different spin that I'm going to put on it is, yes, it's encouraging how they did, but I also find it very interesting that that margin-positive resection is one of the most reliable predictors for worse prognosis in a group of patients that had peer-reviewed, investigator-reviewed radiation therapy. That association actually went away in terms of the margin-positive group, and I think that was a real credit to the investigators in terms of investing the time and the effort for the quality control for the radiotherapy. The other thing that I just want to point out, because what I talked about earlier in the talk was this local failure pattern with extrahepatic cholangiocarcinoma, and I think it's important to keep in mind the numbers that I had shown, which were about 35 to 70% local regional failure risk, depending on what series you look at. And if you do the math and you add up all the local recurrences in these different columns for the distal or hilar carcinomas, and then divided by the number of patients in these two groups, you end up with 11 out of 51, or a 21% local failure rate, which I would argue compares actually favorably to the 35 to 70% local regional failure rate noted in other historical series. So in conclusion, I would say that the role of radiation remains unproven in cholangiocarcinoma. However, the clinical risk and significance of local failure suggests a need for improvement, especially recognizing that there's a quality of life impact to these patients. The majority of cholangiocarcinomas seem to be KRAS wild types, suggesting that perhaps they may be better responders than their cousins in pancreatic cancer. And there is emerging data suggesting that high-dose RT can control intrahepatic cholangiocarcinoma. Additionally, the SWOG data does suggest that when adding RT, even patients with positive margins can have somewhat better overall outcome than historically demonstrated. But what I think this really leads us to is we need to support our trials. There is currently an open randomized trial for intrahepatic cholangiocarcinoma evaluating the role of radiation in patients who are getting chemotherapy, and we're all awaiting the activation of the SWOG concept, or the North American concept, as Jennifer mentioned, that is going to look at adjuvant chemotherapy plus or minus chemoradiation. We're never going to know unless we commit to these trials, but I don't want to be too flippant in saying that's all we need to do is we need to try hard. The reality is that these are rare cancers. Randomized trials are hard to do, and they're hard to get patients to accept randomization. And this is not going to be a trivial issue in actually completing these randomized trials. I'm well aware that in England, Dr. Hawkins is having a very difficult time in getting her randomized trial in intrahepatic cholangiocarcinoma of chemotherapy plus or minus SBRT up and running, and she actually has a feasibility endpoint because of her concern in even being able to accrue to such a trial. But I do think that there is some potential signal that we need to study in further detail. And again, I'd urge all of you to continue to keep your heads up and to continue to plug away at this problem. Thank you very much.
This is just a general question to all three of you. We've tried gemcitabine, we've tried Xeloda, and we're not big fans of this in pancreas cancer either. So why do we think that it's going to work here in a big and meaningful way?
So this is for Jennifer, the proponent.
When you say you're not a big fan of it in pancreas, you mean that you want something better than that? Yeah. Well, I think we all do, but even the impact that 5FU or GEM has had in the adjuvant setting in pancreas is nothing to scoff at. And it took, I've been in debates where some people argue it might have greater impact than surgery at times. There's no doubt that it's not a great fix, but we don't want to throw away, we don't want to throw out our steps forward just because we get excited about molecular biology and hoping to get a magic bullet that we haven't found yet. So I think the reason we talk about 5FU and GEM is because they're both such active agents, relatively speaking, in biliary cancers, but we need to do a trial, and I think the trial has to have GEM and cis in it, since that is the standard of care in the advanced setting.
Can I comment, Jennifer? Ted talked a lot, compared it very well to pancreas cancer. So we have learned in pancreas that what sounds good is not all, what's a good idea doesn't necessarily apply in a trial. So with the SPAC studies, 5FU and GEM are still comparable to each other. And let's not forget that all the adjuvant studies that have done with gemcitabine in pancreas cancer, the control arm has continued to improve and improve, whereas the study arm has not really done that well.
Yeah, just a follow-up to Renuka's question, mainly for Jennifer and for Milind. The case you mentioned it was extrahepatic cholangiocarcinoma. I'm assuming you mean distal and not hilar. And the reason for that is, I come from a very pancreas-heavy shop as well, and so we tend to treat the distal cholangiocarcinomas very similarly in an adjuvant fashion with chemotherapy, at times radiation. So I'm curious as to what, in your respective institutions, how you guys handle the distal cholangiocarcinomas as far as adjuvant therapy, particularly given the fact that we'd like to split out and get individual trials for every site in the periampullary region. But as you know, the ampullary subset of the SPAC trial did not show benefit for adjuvant chemotherapy.
So I think Jennifer's data was, I think, the biggest in terms of extrahepatic, and now Tony's study, the SWOG study. I don't think that that distinguishing hilar from distal, that degree of subtlety is not yet there. We treat extrahepatic as extrahepatic, and yeah. I
agree. I mean, I guess an argument could be made with, I've left out the periampullaries and the ampullaries, but I mean, you could lump, again, they're another tumor that probably has a little better prognosis, and do you lump them with pancreas or do you lump them with biliary? And I think you could debate in different institutions. Do you lump them with pancreas? Do you give them an adjuvant? Well, it's the same drug,
it's
so
sort
it
of like
so it's
really
the
like
same
pancreas.
drug, so
if it's distal,
it doesn't matter.
We treat them like that. Yeah.
I enjoyed all those talks very much, and I was also pleased. I'm a surgical oncologist, so I was pleased that surgery quality was part of the discussion. But at the same time, I think that probably the role of surgery was a little overstated. The reality is that there aren't very many tumor models in which the extent of lymph node dissection actually changes survival. There are data that support that in some, but certainly not in this situation. And the other thing is that it's unlikely, very unlikely, to be able to get 13 lymph nodes from the hilar region. Having been there on numerous occasions, I can tell you that it's very infrequent for me to see that. And I think probably if you see 13 lymph nodes, that's probably a surrogate for some extraordinary biology. So just on a go-forward basis, I think that, having quality of surgery built in somehow into adjuvant chemotherapy trials is important, but at the same time, we don't really know what the quality indicators are in this disease.
Yeah, I take that as a comment, and you know more than I. But as you know, with time, supportive care, good quality surgery, good quality preoperative imaging, patient selection, all of those issues, I think, do matter. And a tertiary place like you come from, I think those issues are better handled. So I think it all factors into surgical outcome, not necessarily lymphadenectomy.
But Oliver, surgeons could come up with a consensus as to what would be considered state-of-the-art resections for a patient going on an adjuvant trial. I think we have that, right?
Yeah, I think we have some indicators, but at the same time, I don't think we're at the point where we're going to be able to say this is the standard procedure. We could sort of lean things one way or the other in the design of a trial.
I'd like to say about radiotherapy. So I'm originally come from Japan, and in particular in my country, so many of the radiologists are reluctant to perform the radiotherapy after the insertion of the metallic stent, because in the cholangiocarcinoma, so insertion of the metallic stent may affect the which cause a fatal outcome with radiotherapy. So have you experienced any severe adverse effect with, in terms of the radiotherapy with a metallic stent? And I'd like to ask your opinion about this issue.
Where I probably treat the most metallic stents is actually in locally advanced pancreatic cancer. I think that arguably MD Anderson has the most experience in the world treating metallic stents. But we haven't actually seen it to be an issue, and we don't actually even, it doesn't even come into consideration when we're evaluating someone for radiation.
So we don't use a lot in cholangio as such, but in pancreas, we almost routinely put metallic stents in operable patients who get neoadjuvant. So it's not an issue in that disease, and probably the same with distal cholangio. It might be the same, yeah.
I see. Thank
I
you.
might add, where we have it a lot is in the Klatskins, and I like the metal stents better. And we do have a program for neoadjuvant therapy transplant, which I don't really want to get into. But the point is that the radiation oncologists seem to want those placed. We want to make sure the patient's free of cholangitis, and then they plan their conformal radiation. They don't like the stent changed and manipulated during the radiation field. But other than that, it really hasn't been an issue at all.
Okay.
Yeah, so thanks. One comment and then a question. The Japanese S1 study is completed. It's under review. I did not review it, but what was asked. You can make the argument that these tumors all have micrometastases at the beginning, and that the reason some don't recur is that there's immune editing going on. And immune editing is very important. You can also make the argument that systemic therapy can adversely affect immune editing and increase recurrence rates. And so I think we have to be very careful. We really need to be evidence-based.
So Greg, about S1, S1 just works very well in Japan, but not so much certainly in North America. And in pancreas, for instance, it's fabulous.
Yeah.
But yeah, your view on metronomic chemotherapy and immune modulation, certainly is important. Yeah.
I have a comment and a question. The comment is, obviously you can't have adjuvant chemotherapy without having surgery. And while a certain level of surgery we could probably all agree on, the majority of patients don't even have access to that for whatever the barrier is. And probably a much simpler way to massively improve some of the survival outcome is to improve access to places and doctors. And this comes down to myself as a surgeon, gastroenterologist, medical oncologist, primary care. It may even have to come from outside of the medical community because we're not very good in the US at regulating who goes where. So I think it comes down to a question that's much simpler than mutational analysis, which is education and advocacy. Because yes, while taking out 5 lymph nodes may not extend a patient's survival, it properly stages the patient, allows them to be considered for adjuvant therapy. So I think that's another part of it that none of us as physicians, we all struggle with this. I don't know what the right answer for it is. At all of our institutions, there's not enough of us to take care of all these patients. But that is a major side to this that I don't think we have an answer to. And my,
So in the UK, there is very much a centralized system. So we have surgical centers serving a certain region. So for example, in Manchester, we cover a population of 3.2 million, and anybody who's diagnosed with pancreatic cancer, which is potentially resectable, or cholangiocarcinoma, would then go into the single tumor board, a single MDT, covering the whole region. And there is an auditing process to ensure that if a patient has been diagnosed, they have been seen by the tumor board. Even if they've got stage 4 disease and it's not possible to do anything more than just supportive care, the case has to go through the subspecialist tumor board. So at least that allows a degree of greater access. So it's usually done, it has to be done within 2 weeks. It's usually done within a week in terms of the assessment. So we have a weekly tumor board, which is now split into 3 sessions. The pancreatic session starts at 8 and finishes at 10:30, and it's got 70 or 80 patients on it. We have then the liver tumor board, which goes on for another hour and a half. And then in the afternoon, they have the colorectal liver metastases. But again, every case has to be discussed.
It's tumor day.
and then
You need an 8-day week.
one quick question. Should LVI be included in assessing patients for adjuvant chemo? Because there's now some large retrospective but multi-institutional studies where the patients that are LVI positive are different than the patients that are node positive. That one does not equal the other. And the recurrence curves and survival curves seem to mirror each other.
I would agree with those comments. I think when we plan an adjuvant study, we obviously have to collect and stratify for those things. We couldn't address that in our meta because it just wasn't reported reliably. I think how we exactly define higher risk stratifications going forward is going to be challenging, and we haven't quite nailed it all down, but that's certainly on the table for sure.
So I don't know about getting 6 nodes or 13 nodes or 100 nodes, but there's always a way to get more nodes. My question is there a way that surgeons can delineate the actual location of the nodes? Because there are some standard locations of nodes. And in fact, the analogy of sentinel nodes for breast, some have argued there is a chain, a progression, a sequence by which lymphatic drainage from the liver ultimately ends up in the aortocaval groove. So both for study purposes and for helping you guys determine whether there's a role for radiation or chemotherapy, is there a way you would like in your fields for surgeons to label nodes, mark where we got them, and then thereby figure out whether if there's a distal node, it's probably the cat's out of the bag. But if there's something in the perihilar location or even over the GDA, that may be different, where you may be able to make a decision or at least study it. Have you thought about it that way? Because we really just give you a clump of nodes, but there may be a better way to consistently, geographically label those nodes. And then number 2 is, when does adjuvant, let's just say you do a big resection, the patient takes a while to get better. At what point is it not adjuvant and it's just reactive chemotherapy?
I think as a radiation oncologist, I think the nodal question is very interesting. It's sort of the reverse, it's sort of the question that Neoptolemus's group looked at in pancreatic cancer in the reverse direction, where they demonstrated that patients with periaortic nodes, 16, station 16 could actually have some cures, but once you had a station 8A node or a hepatic artery node, none of their patients in their series survived. So it's sort of the reverse flow direction. I think that's actually that would be very helpful information and very interesting information to have prognostically regarding where exactly the node was positive. In regards to the duration after treatment.
So since we're borrowing data from other cancer sites to guide us, there is, the adjuvant trials in colon kept things to 2 months, and there's some data to suggest the earlier you start, perhaps the better. Pancreas allowed, correct me, out to 3 months, 4 months?
Yeah, it's about 2, but as
The
you know,
trial, the adjuvant trials now allow 3, I believe, right?
These are rules we have sort of created. I don't know where
Kind
they
of
came from.
So when you're sitting with a patient in front of you and you're using non-level 1 data and they've had multiple post-operative complications and they're seeing you at the 4th and 5th month, it becomes very difficult to justify an adjuvant approach. So usually I will just say quite firmly no and agree to follow them, because I don't quite have the strength of conviction there. I suspect that earlier is better, but what will we do in the trial, Anthony? Will we call it 2 months or 3 months? What do you think? 10 weeks, a compromise, 2.5 months. I agree. They gotta be healed.
I'm just going to comment on the nodes question that Robin came up. The Japanese have been very good about mapping out the flow of the lymphatic stations between liver tumors, pancreas tumors, and so forth, to the point that for intrahepatic cholangios, if it's a left-sided intrahepatic cholangio, they'll do a left-sided nodal resection along the left gastric and celiac, as opposed to a right-sided intrahepatic cholangio. From my own experience, and I think Peter knows as well, is when we're at Memorial, there's basically the first step in any kind of Hepatic resection or gallbladder cancer is to cocarize the pancreas and get to the aortic cable space. Because if those nodes are positive on frozen section, I don't believe that the patient would benefit from even the resection. And so I think that's something very important, the location.
Can I ask a surgical question to a surgeon? So in intrahepatic cholangio, I rarely see any nodes, less than a handful. Is there a technical reason why dissecting or removing is?
Absolutely no. We do a nodal resection. Sure, that's a good point. No, so for example, for a gallbladder cancer, we routinely harvest all the portal lymph nodes to get that staging information. There's no reason you can't do that. I think for the most part, surgeons have shied away from doing that, mainly because they were doing liver resections for hepatocellular carcinoma, where we don't really know what the nodal harvest at that point makes sense. Peter's point is correct, though. When you're doing a Hepatic extrahepatic bile duct resection, you're automatically getting all those nodes with it. But it's an active area of debate at our surgical meetings. Should we do routine lymphadenectomies for intrahepatic cholangio? And I think the answer is probably yes. Mm-hmm. We talked about designing a trial, but we couldn't, with the population being so small, we could never adequately power it.
But does a distal, like a very peripheral intrahepatic, would it drain to the portal nodes?
Theoretically, that's the nodal regional basin, unless it's going all the way up, because I've seen mediastinal nodes sometimes be positive if you have an intrahepatic cholangio that's up high. So it kind of depends on what the drainage pattern is.
Yeah. Okay, that's helpful.
Because that, Tim Pollock's, it's quite compelling that it might be useful. Yeah.
That's why in that study, as you mentioned, it wasn't 100% nodal retrieval.
Mm-hmm.
Maybe we should do that. That's something that we need to figure out.
Sure. So I don't mean to keep beating in the lymph node, but I think it's very difficult to say, well, we're doing adjuvant chemotherapy versus just palliative if we don't know the standard of how many lymph nodes we get. And so I think that's a very important question. And the other thing is, for example, for gallbladder cancer, do they routinely take the gastrohepatic ligament out? Because it's a lot of, up to 45% of the people that are negative in CTs and staging, you can find a positive there. And so I would like from the surgeons to tell me if, what do they think about that? That's okay, no problem. So basically, I just said that, to do adjuvant chemotherapy, you have to make sure it's curative. So you need to know if whether it's N1 or N0. So it's very hard to define, if it's only 6 nodes, whether it's really like that. And I just was wondering is that whether we can find an extent where we, in gastric 15, in colon is 12 or whatever. And also the sides, like he was mentioning, if you have in the left, it's very different from the right. But you guys know better than me that the liver drains in 3 different directions, going up, middle, and down. So I just wanted to comment on that. And also the gastrohepatic ligament seems to be harbor always a high percentage of metastasis. So I just want to know if that bear anything when you do the surgery.
Sure. So part of it is that people have looked at numbers 3 and 6 with biliary cancers and gallbladder cancer specifically. The biggest problem with all this, and this was what our colleague mentioned before, is there's times I'll spend 30 minutes skeletonizing the whole porta hepatis. There is nothing left there, and the pathologist tells me I have 2 lymph nodes. And then there's times when I spend less time because there wasn't as much invocation. I take out what I thought was 2 lymph nodes, and the pathologist tells me I have 8 lymph nodes. When there's 2 lymph nodes, I call them and I say, I took out every single thing there. And then they say, well, we went back and we looked and we found 2 small ones. So now it's 4. So you have to take all this with a huge grain of salt. A lot of it depends on pathology and how much they're looking. I think the answer is we should be doing them in all cases. Every biliary tract cancer, I think, we all think this, as a surgeon, should have this resection done of the lymph nodes so that we're properly staging patients. I don't think numbers are as important as actually just doing it.
And that's why it's important, the numbers that said 1 or 100, if you can say where you got them, you know you got them. So that over the TDA, that over the hepatic artery, that to the left side of the right, behind the pancreas. And that's why the numbers aren't so much important as where they are, and that'll probably help you more. Last question.
Just a final question is, given the limits of surgery and the precedent across a range of other GI cancers, should we be thinking about neoadjuvant trials rather than focusing on adjuvant where we have delays and we get less information?
I totally agree, especially for distal cholangio, which is, phenotypically somewhat similar to pancreas. We kind of do that anyway, but we need to have neoadjuvant trials, especially for extrahepatic cholangio, I think.
I think that there's also, though, a significant, if one is going to take a neoadjuvant strategy, there's a significant education and advocacy aspect. We've had a neoadjuvant trial at our institution. It's a parallel arm design where if you're resectable, you get neoadjuvant chemotherapy, and then you have surgery. And if you have unresectable disease, you get neoadjuvant chemotherapy followed by high-dose radiation for intrahepatic cholangio. But the problem is all of the patients that we see referred to us have already started therapy. So our idea of doing this neoadjuvant treatment, they either have started therapy or something happened and they just can't get on study. So we are having a very hard time accruing to that study, even though our philosophy as of a few years ago was identical, which is we'd love to front load the chemotherapy before we take them for a major hepatectomy.
It's okay. I'm done. I was just going to, I was going to say, echoing, the neoadjuvant idea is very appealing, and I don't think you'd get any real pushback. The problem, again, is you're delaying the definitive surgery. So you need to be very confident that when you're doing that, that you're delivering an agent that can have an impact on survival, because then the buy-in will be very poor. So unfortunately, it takes time. You kind of have to prove it post-surgery and then move it forward. But we would all be, and gallbladder is another great example where that would be really important to do. So that would probably be the next trial once we prove an adjuvant benefit to some treatment, for sure.
All right,
Okay,
thank you very much, everybody. Thank you. And I have to comment on that especially, SWOG and NCI Canada have been really quite instrumental in trying to build the adjuvant program going forward. And this is always a kind of standing item on our agenda for the task force. So it seems all the intelligence we wanted to just kind of like was given to us here. So thank you very much, everybody, for telling us where studies stand, because this is where we're trying to gather the info. So